Good morning, everyone. Thank you for coming to the Big Data Health Science Center November seminar. We are honored to have Dr. Katherine Theall from Tunand to give us the talk today. So Dr. Theall is a professor at the Tunand University School of Public Health and Tropical Medicine. She is a senior director of the Tunand Violence Prevention Institute and the director of the Center for Women's Health Equity Research. As a social and spatial epidemiologist, her research focuses on reducing health inequities by understanding and altering neighborhood environment and the social policy in underserved population, locally, nationally, and internationally. She has been PI or co-PI for more than 25 federally and privately funded research and training award, and has a highly interdisciplinary background. With education and the practical experience in social, spatial epidemiology and the community health and the prevention sciences. Her work involved close collaboration with both state and the city government, as well as international partners, where she has been involved in research, programming, and the translational efforts to improve health equity and well-being. So the title of the talk is Place Matters, Utility of Geospatial Data in Health Research. So before we welcome Dr. Theall, please just a reminder to hold all your questions to the end. You can either raise your hands or submit your questions through the chat. So without further ado, let's welcome Dr. Theall to give the talk. Thank you.
Thanks, Xiaoming, for the introduction. Can everybody see my slides?
Yes, you should switch the display.
Switch display, okay. Sharing the wrong one, you'd think we would. Okay, how's that? Wrong display?
Yeah, it still didn't swap it.
I think, let me stop sharing. I think once I am in PowerPoint mode, it kind of gets tricky. Okay, I'll do it this way. Okay, give me a sec. I'll swip. All right, how's that?
Yes.
Okay, great. Well, it's great to be with you guys today. As Xiaoming said, I'm epidemiologist by training, focusing mainly on neighborhoods and health and kind of place-based factors that shape broadly many health outcomes and inequities in those outcomes. So first, before I start, I do want to thank all of my collaborators and colleagues, students, study participants, as well as funders for some of the work I'll be presenting today. This is definitely a team effort, particularly when we talk about geospatial methods. So I've learned a lot from these folks and continue to collaborate. What I'd like to do today is just give you a bit of background first, and then really discuss place-based measures, methods, some issues to consider if you're conducting this work. And I'll kind of infuse some empirical examples within the talk. And then hopefully we have some time for discussion and questions. And like real estate, health is location, location, location. Many of you may have seen this quote from George Kaplan, who is a great social epidemiologist. And, you all know place matters. We all do, right? Many of you have probably seen similar maps. This is a map of life expectancy in New Orleans, Louisiana, where I am now and where Tulane sits. And we can see differences, just based on where people live. So in this case, a baby born in one of the poorest neighborhoods of New Orleans is likely to live 25 years less than a baby born just 4 miles away. And this plays out in cities across the US as well as internationally. So we know place matters. And there have been many studies, a growing number, demonstrating the effects of place, particularly neighborhood effects on health and a variety of health outcomes. This is an older graph from my colleague Dustin Duncan, and this is mapping publications from 1980 to 2013. But if we extended that out to today, it's been growing exponentially over time. So There's a lot of interest in this work, but it's not new. For those epidemiologists in the audience, you might recognize this map. And we probably don't have time to take a poll, but this is mapping the cholera epidemic in 1854. This is, John Snow's work, often coined as the father of epidemiology. And so, spatial methods in place have been around for many, many, many years. For those sociologists in the room, maybe some social scientists, you might recognize this map, which is seminal work from W.E.B. Du Bois, mapping of racial residential segregation in Philadelphia and showing, the impact of disinvestment, particularly among Black Americans. So again, another father of spatial epidemiology. So it's been around for a while, this type of work, and there's been a number of wonderful resources for individuals interested in taking a place-based or geospatial approach. These are some, key go-to publications and books that have been available for a while. There's a new spatial epidemiology book coming out by my colleague Chris Morrison and others at Columbia, which hopefully will be out soon. And then there's Duncan and Kouachi's wonderful second edition of Neighborhoods and Health, which has been a go-to of mine for a lot of my teaching and research, and some of what I'll talk about today is covered in this this piece. So just some good resources from a book perspective, and again the literature's growing on many of these methods. So we'll just touch the surface today. And, thinking about spatial methods, geospatial methods, there's a lot of utility in taking this approach. If we, in public health at least, we talk a lot about social determinants, and this offers one wonderful approach to addressing social determinants and really contextualizing individuals, populations, really thinking about what puts people at risk for risk, right? So come in some of these upstream drivers, which are really important as we move upstream, and spatial methods do just that. When we think about mechanisms, there are many conceptual models, but this is one by Ana Diaz-Rue, and thinking about how neighborhoods in particular may shape health with overlapping characteristics that might be physical in nature, things such as the built environment, maybe food or recreational resources, as well as social environments, how they might impact behaviors, perhaps stress, biologic factors that can shape health and health inequities. And these might all be moderated, these might all be moderated by personal characteristics, material resources, psychological and whatnot. But what I love about this model is also reminding us to, even though we might be focused on neighborhood factors in a spatial or geospatial way, considering what's shaping those neighborhoods. And so, historically, neighborhoods are shaped and have been shaped here in the US and elsewhere, and they continue to be shaped by resource allocation, segregation, and other means. But in order to understand, how place affects health, we do need spatial data in most cases. And so what is spatial data? It is basically just information with location information. So data that contains information about specific locations. And of course, that information may change with location, but without location, the data is no longer spatial. And so this can take many forms. Some of you may be familiar with working with some spatial data, and you may hear this referred to as geospatial as well. And it is, forms that many of you may have seen might be census data. So if we think of maybe the proportion of families living in poverty in a census tract, or maybe block group, a zip code, that can be very spatial. We might have address information, perhaps for, patients in a clinic or members of a study being conducted, or place, right? Many things come with address information, and that can be spatial. We might have GPS data, which is real-time location. And then we also have, crowdsourced data, which now has a lot of spatial attributes that can be used for research, which is exciting. And so, the figure on your right kind of depicts the layers of data we typically work with when you're working in a geospatial environment. With geographic information systems, it's typically a method of layering data in order to conduct some of the work. And so, again, just a depiction of that, really, combining spatial data, perhaps with other data that's available as well. And, broadly, spatial data come in two forms. There's vector data and raster data. And vector data, oops, sorry, y'all, my mouse is really, really sensitive. Vector data is just specific features on the Earth's surface. So shown in the figure there, you can see kind of a real world example of a building. A vector data would show you these attributes as a point, maybe a line, a polygon, some data forms you might be working with in this space. Polygon being, if we think of census tract or block group, an aerial unit. And then raster data is just the pixelated version of that data. So you can see that on the far right-hand side. And it's used, different data types are used in different procedures geospatially. Maybe more, depending on what you're doing in geospatially, you might be using vector more than raster, but it again depends on your field and the data source as well. This is just another schematic of these different data types. Again, point data represented in the vector format, a line data, maybe a roadway, a roadway or GPS points, aerial data, perhaps census tract, and how those two data types would be represented. And, in this linkage and layering, there are different ways to do this. Again, it's going to depend on the data that you're working with. And of course, you can link more than just an outcome and exposure. We might be linking, other confounders from a public health perspective or moderators. But the two main ways to do this would be geocoding or georeferencing. So if we have the address of individuals in a study or, hospital cases or locations, we can georeference that spatially. And all packages allow for geocoding. Typically, you want an 80% or greater match rate. And once the data is georeferenced to a map, you can do many things with it. You can use the point itself, but you can also maybe aggregate up to calculate rates. You can calculate distance. You can do a number of things in that respect. Second method, which is also common, particularly in public health, given that we often don't have identifiable point data, especially if we're talking about maybe a health outcome, but it might come with administrative identifiers that can then be linked and layered. So, for example, if we're looking at, rates of HIV in a given geographic area and want to link that to rates of poverty in the neighborhood, we can perhaps link on an administrative identifier. And that's often, more often than not, a census identifier, a FIPS code, the Federal Industry Processing Standard Codes. And have an example of a FIPS code down on this slide here. Again, it depends on the scale in which you're working, but all states have FIPS codes. If you're down to the block group level, that would take on a form like this, where the first two numbers indicate the state, the next three are county or parish here in Louisiana, the next six are census tract, and then the final number is the block group, and able to join and work in these different geographic spaces. And that's typically done with aerial data, but again, you can, join aerial data to point data as well. A lot of utility. In terms of, different types of data that can be collected spatially, there are many forms. There's some traditional methods, current methods, and emerging methods, and I'll show you some examples of each of these as we kind of go through the talk. But traditional methods include self-report. We might be asking people on a survey about conditions in their neighborhood, or maybe, shopping patterns, travel patterns, that sort of thing. We can also, systematic field observation is a traditional method, and I'll show you it's really transformed over time. But that is just, you as researchers out in the field collecting that place-based data. Current methods that are probably more common now are these, GIS linkages. So linking, different characteristics geographically in some of the examples I just showed you. And that also can include some web-based geospatial data, which is also really common. If we think of walk score, mapping police violence, there are a lot of web-based geospatial data that can be used and applied now, which is great. And then some emerging methods include those that are, looking at GPS with wearable or carryable monitors, maybe on a phone and smartphone, which is growing in popularity. There's also a lot of crowdsourced data, which is another method. growing in popularity as well. And then also social media and other internet source data. So these are some of the emerging methods that are out there. And yeah, in terms of systematic observation, so, back in the day, and even today, depending on what characteristic you're examining in a place, this would be, paper and pencil, people out in the field collecting data. But with the advent of Google Street View, Google Earth, this has really transformed how we can collect neighborhood data or place-based data. And this is an example from Candace Oger's work, which we've applied here actually in a few of our studies, looking at Google Street View for characterizing neighborhoods. And so you can see in these 4 examples, the upper left-hand corner is characterized, as noted in the bottom, as a well-kept neighborhood. Children and amenities are visible on the street. Roads and sidewalks are in good condition. Slide B, or picture B on the bottom left-hand side, characterizes poorly kept sidewalks, trash containers, graffiti, sidewalks in fair condition. C is characterized as a deprived area. There's a vacant lot in poor condition, a heavy amount of litter, which is probably hard to see in this slide, sidewalks and roads in poor condition. And then in the example in segment D, this is characterized as a comfortably well-off residential area, roads and sidewalks in good conditions, no evidence of litter, graffiti, and that sort of thing. So this type of method is, very dependent on the researcher and coming up with what is to be captured in the neighborhood and characterized. And so there's some subjectivity as well, depending on what's being captured. But it has grown, and even, there have been several studies coming out now. One of our colleague, Peter James out at Harvard, and some others, really using deep learning algorithms with Google Street View to capture these place-based features in, a much bigger data way, because even using Google Street View or Earth, takes real-time staff and observers rating those conditions. So that's one example. And, in thinking about the utility, I'll give you some other examples as we go along, but, there's a lot of utility for spatial methods, again, depending on your field. And, you can use this approach with individual data. So if you have, let's say, a cohort study, case control study, as well as if you're thinking about things at ecologic levels, maybe more population-based. Many of these methods include descriptive capabilities, bivariate or bivariable or multivariable methods. And this is one example from an HIV research perspective, just to give you a sense of things you could do, including storing and measuring spatial relationships. So what's the distance between homes of newly diagnosed cases, HIV cases, and the closest Ryan White clinic? You can look at spatial relationships, so really looking at, how things are related spatially, maybe HIV and poverty. You can analyze attribute and feature data, so really counting maybe the number of cases or the number of clinics. GIS is great, as I mentioned, for managing multiple data sources. So kind of creating those layers and managing the data. You can also use GIS to identify spatial patterns, maybe a hotspot analysis, or explaining spatial patterns. And I'll show you 2 examples of those as well. And then again, you may just be using GIS to calculate an exposure, which then could be brought back into your, standard software, analytic software too. So that's common as well. There are also lots of software programs available for thinking about using geospatial data. One, of course, is Esri's ArcGIS or ArcPro. ArcMap is still in practice as well, but ArcPro is the newer version with more bells and whistles. Some freeware software, which are great, is QGIS, Geoda, which is also wonderful, out of the University of Chicago, Luke Anslin's program. Geoda also has wonderful tutorials, comes on different platforms. It is more focused on spatial analysis and statistics rather than cartography. So if you're doing a lot of mapping, maybe QGIS or ArcGIS Pro might be, a better choice there. And then there's a lot of programming languages, of course, that have GIS and spatial analysis packages, like, of course, R, Python. Python is actually what's working behind the scenes in ArcPro. And then SAS, Data, some other packages also have bridges. to spatial methods. So there's a lot of software available depending on your need. And, there's, again, a lot we can do methodologically, both with how we collect the data and then also, what we do with that data. This is what I think is one of the more recent reviews of spatial methods and epidemiology by Amy Auchincloss. And what they showed was, some of the more frequently used methods in this time period, so 2000, 2010, included proximity. So just looking at how close, maybe individuals were to a given exposure, aggregation, so aggregating up maybe to a neighborhood level for people in a study. Clustering is another method that's commonly employed. Smoothing or interpolation, which is great for those of us working with maybe sensitive or small numbers data for certain outcomes like HIV or homicide, which I'll show you in a bit. And then spatial regression techniques are also very common and growing, and they typically include spatial autoregressive models. So that includes spatial lag, spatial error models. Spatial lag, we may be modeling exposure in the target neighborhood's neighbors and how that might impact individuals maybe in your target neighborhood. So there's a lot of utility there. Geographically weighted regression is another one that is popular. And then of course, Bayesian regression techniques as well. And yeah, just shown on the figure to the right are the number of articles at the bottom of the decade. And then in 2010 is the darker colors. So those are the more commonly employed methods, at least again, in a public health setting. So to give you an example of this, so this is looking at some data we have here in New Orleans, and we're interested in this example, thinking about youth homicide. Where does it occur in the city? Is it clustered, right? Do we see random patterns of homicide or something less random and spatially clustered? And so this is just an example of mapping homicide at two different levels, a census tract and a block group, both of which are often used, as I'll talk about in a second, as maybe a neighborhood. But we can see with our eye that, perhaps these outcomes look spatially clustered, right? Things don't appear to be so random in space. And the shades of red indicate higher levels of youth homicide, shades of yellow, lower levels. And, that's great, but we also want to test this. And there are many methods for testing whether an outcome and exposure is clustered. One of the more commonly employed is Moran's eye. And in this case, Moran's eye ranges from -1 to 1. And if it's positive, it indicates clustering. If it's negative, it indicates more of a checkerboard pattern, no clustering, no pattern. And in this case, Moran's eye confirmed what we see in these maps, that yes, there is some clustering of youth homicide in the city. And this was from 2018. We can also look at, from an interpolations data smoothing perspective, taking, in this case, homicide among younger youth, less than 18, which are really small numbers, not stable as rates, and thinking about patterns of youth homicide for this age group, potentially over time and by place. So using kernel density to create some spatial smoothing, and then comparing 2015 rates or patterns to 2020, we can see that, yeah, it looks like these hot spots of youth homicide have changed a bit over time in that time frame, with, again, the darker purple indicating higher rates of youth homicide. So two very descriptive examples in that case. We can also take this data as an example and, maybe think of what's driving youth homicide. And, are there things in the neighborhood that might be creating these spatial patterns or leading to more or less rates in the city? And so this is an example of looking at markers of racism and its association with youth homicide, again, at a very ecologic level. So this is at the block group level, taking rates within the block group, and then also measures of structural racism or institutional racism in the block group, and looking at that association. And we looked here in this case at rates of police stop and frisk in the neighborhood. So stopping and frisking by police officers for individuals within that block group. And what we found were neighborhoods with greater stop and frisk encounters had higher rates of youth homicide. with a greater than twofold relative risk. And then we looked at a segregation marker, index of concentration at the extremes, and compared low privilege neighborhoods to high privilege and medium privilege neighborhoods. And again, we see kind of a dose response relationship in that neighborhoods with less privilege had higher rates of youth homicide. And these are all controlling for other characteristics in the neighborhood, such as concentrated disadvantage, age of the population, education. So just an example of, what you can do. And again, this was done in traditional software. So kind of taking rates and things created in GIS and then brought back into regular software platform. Another example, a colleague of mine, Dave Shea, and others have conducted looking at social media data. So this was a study using Google Trend information with Google Trends denoting structural racism. They search for searches containing the N-word, looking at its association with mortality rates and specifically race-specific mortality. And you can see in the map on the right, these are designated market areas, which is, to my knowledge, the smallest geographic unit we can get out of Google Trend data. But you can see the areas in red were characterized as having higher levels of racism, and then green being the lowest. And what they found was an association with Black mortality, specifically with about an 8% increase in all-cause mortality for areas with higher levels of racism. And then looking a little more specifically, they found this to be higher for certain outcomes like heart disease, cancer, and stroke. So one example of, kind of a social media perspective on this. And again, there's been a lot of studies using Twitter, Reddit. Many of these platforms can be geotagged to some extent. It's changed a bit over time with privacy policies, but there's a lot of utility there. Another example I wanted to show you of geographically weighted regression, which really allows us the opportunity to look at heterogeneity when we think of spatial associations. And so what GWRs do will really run a regression within each geographic context. And so this is an example looking at COVID-19 fatalities in the European region and really that variability across countries. And they were interested in looking at demographic and socioeconomic components as drivers of fatality. And what you can see is, a lot of heterogeneity. These graphs show the R squared, so the amount of variability and fatality explained by, in this case, in the top left-hand corner, income. And we can see, again, the darker green here is a greater R squared. And so it looks like income, played a larger role in countries like Italy, maybe a lesser role in other areas. And so just an example of geographically weighted regression, which I think is a useful tool, again, depending on your question and your data, but from a public health surveillance perspective can be of great utility there. So, there's also a lot of some key issues that we need to think about if we're thinking about geospatial methods and neighborhoods specifically. So if we're kind of getting down to a hyper local level of neighborhood, one is how we're characterizing and defining the neighborhood. There are also some biases and uncertainty that I want to mention for you all to be aware of if you're working in the space. And then also what a neighborhood effect even is. How do we interpret that? And so in terms of characterizing neighborhoods, one of the more traditional ways, and this often is due to data availability, is using administrative units. So block groups, census tracts, counties, perhaps states would not be considered neighborhood, but again, a lot of data will come at the level of the state. And so these administrative units are very common. People have used political units as well, maybe less commonly. Service districts might be another way to define neighborhood spatially. But, from a public health angle, if anything, a lot of our data might have administrative linkages. And again, if we are linking to census data or other maybe exposures, these are common metrics. And this is great. It's offered a lot of utility. We've looked at these units in several studies, but there are a lot of limitations with administrative units, right? Most of us don't really know even what our census tract or block group is, and most of our day-to-day patterns and exposures don't happen in that administrative unit. So it's a big limitation. And there are alternatives to that. One may be looking at individual buffers, perhaps around, studies, residents of your study sample. Let's say if we have a cohort study, really kind of thinking about what is around the home of these cohort members. And this is an example of what that might look like, just drawing a buffer in GIS around the home, around a place, and then calculating exposure within the buffer. And, the size of the buffer varies depending on what you're looking at. Oftentimes, at least in our work, we'll do 0.5, a mile, and 2-mile buffers, but it might depend on that exposure you're looking at within the buffer too. And then it also depends on the type of data you're calculating within the buffer. So if we have point data, typically you'll just count, maybe the number of healthcare facilities or fast food outlets within that buffer. If it's aerial data, such as the yellow and red shades in this map, maybe you'll calculate the average of that value, perhaps poverty, perhaps some other aerial marker within that buffer. And then these can be brought back again into your typical maybe software pattern as well. One other emerging way to think about neighborhoods and collect place-based data is the use of GPS. And so, this might come in the form of wearable devices or, an app on a smartphone that really captures the day-to-day patterns of where people go, what people are exposed to, even within a buffer around the home. And, we don't spend, other than during COVID, most of our time at home, right? We traverse through many place-based contexts throughout our day. And so we've done this in a few studies locally here in New Orleans, looking at, GPS paths over a 2-week period, and then connecting that path to different exposures people might encounter on their path, right? And this is an example of one person's path, looking at offsite alcohol outlets, on-site, also concentrated disadvantage, which is kind of an aerial marker of disadvantage at the block group level in this case. And you can see on, on this individual's day-to-day path, they were exposed to several on-site outlets. This must be near the French Quarter here in New Orleans, but one visual way to depict neighborhood and place-based exposures. And then again, this is typically brought back into a regular software environment because it's really tough to map multiple people in terms of their activity path. So this activity space is growing in popularity and really overcomes some of the limitations I'll mention in a bit, but also can capture reality perhaps in a better way. And so we've done this in a few studies I'll show you briefly. One is the smaller pilot looking at individuals living with HIV. This was a small study, more of a proof of concept to see if alcohol environments, violence environments played a role in daily adherence as well as behaviors and mood and some other outcomes. And so we followed individuals for 2 weeks with GPS collected on their smartphone through an app, and then also with daily diaries collected through Qualtrics. And what we were interested in is comparing, our typical way to look at exposure, maybe to look at the individual's neighborhood, look at the rate of alcohol outlets or maybe the number they might be exposed to. And so in this case, comparing their typical census tract exposure to their activity space exposure, as expected, we saw quite a difference, right? On their day-to-day path, on average, these individuals were exposed to about, 6 per 1,000 alcohol outlets versus just 1 within their residential area. So quite a difference in exposure if we think about it in that sense. And then what we found were some associations between these exposures on their daily path with alcohol consumption, mood, ART adherence, which is HIV medication adherence, with, again, some positive correlations with increasing exposure to alcohol outlets on their path associated with higher alcohol use, marijuana use, feeling mad, not taking their meds, and then inversely correlated with taking their meds. Sorry, not taking their meds because they were high or drunk. So just kind of a proof of concept. And again, this was a small study with 10 participants, but over 250 or 60 or so person days, and then a number of polyline segments. So this is getting GPS data down to the minute for each of these people over 2 weeks. So quite big data. And we're working on, a larger sample as a formative part of an R34 here. Similar sample of individuals living with HIV. These are adults. Similar methodologies looking at daily diary, collecting diary 3 times a day, GPS captured through a software program, which again records every minute when people are moving, and then stationary when they're not, every hour when they're stationary. And so we're in the process of analyzing this, but just to give you a sense of, maybe other ways to map activity space data. This is one looking at, on the figure on the left, this is individuals reporting temptation to drink and then their exposure to offsite and onsite alcohol outlets. And the individual's path in blue is a low temptation responder, and that in red is a higher temptation. And we can see, just maybe visually some differences in exposure between those 2 people. The second map to the right looks at PTSD symptoms and exposure to violent crime incidents is on their daily path. And again, we can see, maybe a little bit of differences there as well, which is great visually, but, testing some of those associations among, an entire sample will take it being brought back into your package, your regular package. So those were some examples. I wanted to mention a few issues that for any of you in the space, working in the space, considering working in the space, to be aware of. And one is the modifiable aerial unit problem, or the MOP. And this is really just a scale effects issue. And the fact that we can see, especially with administrative boundaries and units, differences depending on how we define that unit. If we're looking at maybe block group, census tract, zip code. And so these aggregation effects can, cause some differences. It's something we need to be aware of, and thinking about how we define that aerial unit. And that's really, the goal of the MOP is that definition of an aerial unit, right? And it's important. It's an issue that should be considered, I think, in our, from a public health perspective, and as we think more about causality and maybe how neighborhoods do affect health, or how place does affect health, I think it's also an opportunity to explore relationships between scales. So, kind of thinking about these associations at different levels can also be a means for your testing. At which level does it matter? Does block group food availability matter more than census tract, more than zip code, and so forth? The other issue and bias, potentially a large bias too, that should be considered in this space is the uncertain geographic context problem. And that is that, we don't really know spatially the impact of exposure. We don't have a good sense of the exact timing or duration of exposure that might matter spatially. And so that can really confound results, especially if we're, maybe taking a more traditional spatial approach to our analysis. Now, using GPS, using some other maybe more emerging methods that can help you get at temporality and duration of exposure tries to overcome some of that. And so that's a good move in that direction, but definitely something to be aware of. Folks have touted that it could be a cause of, uncertainty that we've seen in some neighborhood-based studies. But 2 big things to keep in mind if you're working in this space. Another, not so much an issue or a bias, I just wanted to mention that, a lot of the research to date, which has been great, linking place and health, has often not considered moderating effects, and not just kind of the heterogeneity like we saw in the geographically weighted regression model, but how do neighborhoods or places impact health differentially based on other conditions? And so if you're entering this space, just a nudge to consider moderation as you're looking at impact of a neighborhood exposure, place-based exposure. All right, and then finally, the other issue to consider in a geospatial space is, what is a neighborhood effect? Particularly, again, if you're working more hyper locally at the neighborhood level, it's often tough to tease out, depends on what you're looking at, but the effect can be characterized often in 3 ways. This is from Sally McIntyre's work. One could be a compositional effect. So you might see areas that exhibit high rates of an outcome, maybe smoking, because they contain a lot of individuals who smoke or who are predisposed to smoke. So it's very much a compositional effect due to individuals who live in that area. Another could be a contextual effect. So we see high rates of smoking because there are a lot of environmental factors, maybe cigarette outlets, advertising, low pricing, that sort of thing. So very contextual effect, more top-down neighborhood impacting the outcome. And then thirdly, we can have a collective effect, which is, maybe more due to local norms, traditions that might be pro-smoking or pro-behavior that you might be interested in looking at. And oftentimes it might be all three of these things, right? And so if data is available at both levels, it's great to use modeling, more so in your traditional package, maybe a multi-level model, but if you're using R or some other software that can incorporate both the spatial and the multi-level, that's great. But really teasing out the compositional versus the contextual. So if we have maybe socioeconomic status from census data, and then we also have that at the individual level, if we're working with an individual or maybe cohort study as our unit of analysis, we can really tease that out. Is it due to the contextual or the individual? And so something to definitely keep in mind as you're working in this space. If it's a true contextual effect, it really doesn't have an individual analog either, right? If we think of advertising or tobacco outlets, alcohol outlets, food outlets, those really don't have an individual factor to tease out, but potentially asking people in a study about their use of these spaces or establishments could be one way around that. So important to consider. The other issue is that of endogeneity, selection bias, structural confounding. People have, different terms for this, but we don't randomly select where we live, right? And so that's a key issue that really should be considered if possible. And there's different ways to do this. Many people have attempted to adjust for individual factors, that might be associated with living in a particular neighborhood or area. Multi-level analyses are another way. Propensity score methods is a great way to maybe think about the propensity for living in an area or matching on that. But the nagging problem with this is that many of these individual factors that are controlled for could also be mediators or confounders. And so it's kind of a fine balance as you're thinking about how to deal or at least look at selection bias in a study if you're working with, say people nested within neighborhoods. As an example of this too, again, thinking about smoking, neighborhood distress, and low birth weight. In the top example, we can think of smoking maybe as a result of living in a high stressful environment, right? And so maybe it's a true causal effect of neighborhood condition impacting the behavior, impacting the outcome, or from a selection perspective, people select into neighborhoods. Again, that could cause differences in the outcome based on the neighborhood characteristic. So just something to keep in mind. Finally, just a few emerging issues. I think, there's still a lot to learn ideologically with place-based approaches, neighborhood approaches, geospatial approaches, but at least for those of us in public health, really thinking about moving toward more experiments. And experiments are tough, right? But maybe more quasi-experimental designs. There have been experimental designs. The Moving to Opportunity study is a great example of that. Questions on whether it's better to intervene on neighborhood attributes or moving individuals, which MTO did. But there's a lot of natural experiment opportunities available, looking at policy change, again, and for sure in our post-Roe world, natural disasters, social events, these can all offer up opportunity to think about spatially, maybe a quasi-experimental design that could be examined, depending on what you're looking at. So yeah, in summary, there's still much to understand. I do believe heavily that, geospatial tools and spatial methods offer a unique angle and an important one, particularly if we think about interventions and moving more upstream and, addressing health equity in different ways. I think, understanding space and place is really key to that. So Well, this was a whirlwind of information for you all. I think what I'll do, I guess, stop sharing, and we have about, almost 15 minutes for questions. So I ran a bit over.
Wonderful. Thank you so much. Please feel free to raise your hand or put your question in the chat box. We already have a hand up, so you can talk now.
Hello, Katherine, thanks for your wonderful talk. I'm Yu Hao. I'm currently an assistant professor at the Department of Geography in GIS. So I'm very familiar with like the contents you were talking about, and I'm really excited about your past work. So I have a specific question regarding the street view images, because I was also developing like using street view images with machine learning to examine the built environment. But one criticism from like public health researchers and from my colleagues is that they said, street view images, we can observe the built environment, but what's the direct link between the built environment and the public health, the interventions? So how to deal with such kind of issues? Because it seems that because I was training geography and planning, so maybe urban planners can change the built environment design, but public health researchers thought we cannot change the design of the built environment. So what could be the direct link between the built environment and the health? Yeah. So that's my question.
It's a great question. Yeah. And you probably know more than I do for sure as a geographer. You know, those of us in public health, we're very interdisciplinary, so we continue to borrow methods. I think, you know, there's a lot of issues with the Google Street View technology and the assessment too. I mean, one is the lack of the social environment. So really understanding that link between the built environment and the social and the mechanisms through which it might impact health outcomes. So it's a big limitation. I do think, though, there have been a lot of studies, and this is where interdisciplinary work is so important, to test what changes in the built environment might lead to changes in health outcomes. Again, if that data is available, I myself, we're actually doing a neighborhood-based intervention now, changing vacant and abandoned property to look at its impact on crime and violence. And we're working with urban planners. You know, our team is very interdisciplinary. So while there are limitations, I do think in public health, there are many individuals moving into that space of changing built environment, understanding its impact on health. From a population health perspective, it's almost, you know, a bigger bang for our buck if we can intervene on a place-based feature and change health, perhaps easier than individual level intervention. So I think there's arguments for definitely looking at built environments, changing them, but keeping in mind the limitations, because a lot of it is correlational, right? Especially if you're not intervening, just looking at those associations, it's hard to know. And I think with Google Street View, even definitely with machine learning algorithms, but even in the methods we've used for that, the subjectivity is tough as well, right? Many of the raters or the coders are not from the neighborhoods you're coding. And, you know, who's to say whether things are safe or characterized as disordered? I think there's a lot of things to consider there. So good luck. I get your criticism, we get it too, but you can change built environments. Just move to partner interdisciplinarily with urban planners and others.
Yeah, thank you.
Thanks. So we have a few questions and I'm going to go in order that they've been received. So the first one is from Dr. Olatosi, and Banky, I think you're trying to give me a headache with all these giant words. So bear with me as I read this slowly. So first of all, thank you for your presentation. Regarding GWR and heterogeneity, how does GWR deal with autocollinearity with the lack of longitudinal spatial data? Is there any workaround for this issue?
Yeah, it's a great question. You know, right now, at least I've only used GWR and Arc Pro. I believe I'm pretty sure maybe R and some other packages have more bells and whistles for this, but at least in Arc Pro, you can look at collinearity. They're building, there's a variance inflation index that comes when you conduct a GWR. So kind of knowing what might be collinear in that sense for the variables in the model. And then, dealing with that as we would traditionally in a regression model. But to my knowledge, it can't handle longitudinal data just yet, at least in ARC Pro. So I think that's where you'd probably have to, have some merger of GIS or spatial methods with your traditional longitudinal techniques for that analysis. So I don't know that there's a great workaround just yet, but I think it's coming. And again, I'm speaking from an ARC Pro perspective. I'm not an R user, but I'm pretty sure there's probably some good packages that would handle that in R.
Awesome, thanks. The next question is from Dr. Swan Adams, and she asks, gaining access to identifying data to be able to implement geospatial analysis can be very challenging. Do you have any ways that have proven successful in eliminating these types of institutional barriers? Any advice?
So challenging. Thanks, Swan. It's very challenging, particularly for the health, the outcome side. I feel like exposures might be much easier to come by than, looking at rates of, homicide or HIV cases, right? And I think particularly from a confidentiality perspective, it's sometimes impossible for us to get identifiable data. So I think, our workarounds have been strong IRB proposals, really. I should say too, so the maps I showed weren't the individual's actual residents, but thinking about, having, as you would with any IRB application with sensitive data, the procedures in place to protect confidentiality, to aggregate up, perhaps, to have the partnerships with individuals giving you the data, for there to be a better understanding about how you're going to use that. But I think it's other than relationship building, strong protocols for protecting data and means of aggregating up, data disposal after it's used. Those are the big ways we found to be successful, but sometimes it's not, and it is what it is. And so I think what we've often negotiated, say with the state health department with vital statistics, or maybe our local police department for arrest data, is to say, if we can't get the point data, can we at least get rates or some kind of an aggregated form? It's not ideal, but it is a workaround. So
thanks.
Yeah, good luck.
So we have two more questions on deck. The first one is from Shan Chow, Dr. Chow. Okay, now it went away. So she asks, would you like to introduce more about the crowdsourced geospatial data? For example, the data collection approach.
Oh, gotcha. Yeah. So not so much you as a researcher. I mean, I guess you could collect your own crowdsourced data, but really using platforms that are crowdsourced. So if we think of even Yelp, some of these platforms where users are providing feedback, opinions, calling in, many of these platforms do have some geo-tagged or geo information you could use as a researcher to then link that geographically. Kind of depends on the source. 311 calls in a city. Typically, most cities will have the address of the caller, which you could then bring back into a spatial sense and determine the neighborhood or the place. So it's, again, mostly using existing crowdsourced data.
Great. So the next question is from Farnaz. So I'm going to allow you to speak so you can ask your question now.
Hi, can you hear me?
Yep.
First of all, thank you so much for a great presentation. And I wanted to say that I think public health already has taken steps to fill the gap, because I'm an architect and I'm studying the PhD in public health, and I would like to fill the gap, exactly the gap that you mentioned. My question is regarding the raster and vector that you mentioned. You said it depends on your field. I wanted to say if it's possible to mention some example to clarify each of raster and vector.
Yeah, and I guess, kind of field and data source. Actually, the kernel density example I showed you with youth homicide, we had point data for that information. We calculated rates, but when we went down to younger age groups, that rate information is unstable, but we still had the point data, and we used that to to calculate kernel density, and that became raster. So kernel density and other spatial smoothing techniques take on that raster shape. So even within the same field, same data outcome, we have used raster and vector forms for sure. But there might be data that's captured, if we think of imagery files, perhaps looking at remote sensing data. There's some other data forms, perhaps more popular in different fields, that might come in more of a vector format than a raster format. So it depends on the data source, but oftentimes you'll be working with both. It's just, you know, your preference of and need for one or the other might just depend on the data, the question, your area, your field. And that's really exciting that you're, an architect working in public health. It is happening.
Yeah, thank you.
We have one more follow-up question for Dr. Olatosi. And this one I can read easily. He says, is there any algorithmic bias in Google Street View? Recently, Google released Google Vibe. That could be a useful measure of neighborhood vibes. This sounds exciting theoretically, but it depends on how the algorithm is defining vibe. Are you aware of this, and do you have any thoughts?
It's a great question. No, it's our question as well. And it kind of, not just with Google Street View, but with a lot of the AI algorithms. It all depends on how these algorithms were built. And I think for some of the published papers we've found, there's not a lot of the behind the scenes. So I would assume that there probably are and is some level of bias in some of these. So I do think it sounds exciting, but it's hard to know unless you have that detail of how the algorithm was defined and knowing the level of bias and, whether you agree with it, you want to use that data. I think it's good to question that. So we feel the same with a lot of these systems. Same with walk score data, which is a great, geospatial web-based method. And the company is pretty forthcoming with some of their information on the overall index. But if you purchase the data, use the data, it comes with a culture score, some other interesting scores that they're not really forthcoming about how that score was collected. And so in that sense, it sounds interesting, but we're afraid to use it without knowing what went into a culture score. So yeah, great question.
I think this is our last question now from Dr. Chow. And she asks, are there any common apps to collect individual mobility data? Do researchers have to create new apps for each project?
It's a great question. Many of our apps collect mobility data, but we've actually used in the two examples I showed you, Axsoft, which is honestly a truck driving app, but it was one of the more user-friendly that we found, dealt with data. So I think there are existing apps that you could use as a researcher. People have also created their own. So in other studies, we've collected and created our own app to collect that information, oftentimes with more trouble than using an existing app. So kind of depends on your purpose, but you can do either in this phase.
Great. Well, before we adjourn, I have two shameless announcements that you all might find of interest. Next week, we have Dr. Fawn Lee from the Yale School of Public Health joining us here on campus to deliver a presentation called A Bayesian Machine Learning Approach for Estimating Heterogeneous Survivor Causal Effects, Applications to a Critical Care Trial. So that is in person and lunch will be provided. Please register on our website. And lastly, our call for abstracts for the 5th National Big Data Health Science Conference are due next Monday, December 4th. And I hope you plan on submitting. Dr. Theall, thank you so much for a fantastic and incredibly engaging presentation. We all learned a great deal from you, and we appreciate you taking the time to join us today.
Thanks for having me. Yeah.
Bye.
Thank you.